But I was just saying thank you for this opportunity. I really am actually looking forward to the other presenters. In preparing for this talk, I was reminded of what author William Close wrote during the first Ebola outbreak in the former Zaire in 1976. And he wrote, "I bow to the courage of those who take care of the sick and dying." And I want to echo that sentiment today in thinking of those and bowing to the courage of those from all over the world who have responded to this outbreak, who are risking their lives and are there on the ground giving care to the sick and the dying. And I also especially want to bow to the courage of the local folks that are on the ground, the mothers and the fathers and the sons and the daughters, and those who've lost so much and who are giving so much. And I bow to their courage, their strength, and their resiliency. And today I want to share the lessons that my husband Barry Hewlett and I, and along with Alain Epouin, a medical anthropologist from Paris, who we worked together on the outbreak, and just simply to share the lessons that we learned in this outbreak, in the Ebola control efforts in Uganda and the Republic of Congo. And I want to be clear that I am not an expert in these Western African communities or cultures, and nor do I believe in a one-size-fits-all kind of model. So today I just want to share lessons learned, a historic perspective, and as well I want to speak to the human commonalities in responses to acute and or rapid killing epidemics. And so essentially this wraps up my talk right here. I could quit and feel satisfied with just this lesson that we learned. That what we found in our work is that there is another story that's not being told, and it's generally not making the headlines, and at least not often enough. And the greatest lesson that we learned is this, that we have a lot that we can learn from others. We have a lot that we can learn from people on the ground. They have knowledge, they have skills, and oftentimes they have experience, which can aid in control efforts. In terms of community engagement, I would just echo what comes from Paul Farmer in terms of partners in health. I think the community should be engaged as partners in health. And while we certainly hope that anthropology can play a role in assessing and, as someone said, bringing to light the links between health, disease, politics, policy, economics, history, culture, and everyday life, with this outbreak, I just would urge caution that as anthropologists, or those of us working, or those who are working on the control efforts, that we focus on what needs to happen for the people, that we're not just putting words and health education messages out that really on the ground have little meaning, and that the interventions, the recommendations that are made are evidence-based. I also hope that as individuals, as communities, as a nation, that will not become so distracted by our own fears that we turn our attention from West Africa, and that we don't become so overwhelmed with the fatigue and with the immensity of this humanitarian crisis that our compassion is drained, that we close up our wallets and close up our hearts. And so that's my hope. So why we did our work, why we went on these outbreaks in Uganda, in Gabon, and then in Republic of Congo. There were, in our experiences, messages that were getting missed. There were narratives that were being promoted, misconceptions of Africans as traditionalists in the worst sense of the word, as backward and exotic, needing to be saved from the behaviors and beliefs that tended to amplify rather than aid in control of the outbreaks. So our experiences in working in Africa over many years really challenged those misconceptions. And so when we saw these sorts of messages being put, making the headlines, we really wanted to confront that. Representations of people by the media, their beliefs, their practices, as causative factors for the amplification of outbreak really facilitates a narrative that is not only problematic, but it's health lowering. The perceptions of African people by international and national teams impacts caregiving behavior and policy and intervention. And that narrative really needs to change. So what we found, and what I think today is true, is that more than tradition and belief and practices of local people, it's long histories of abuse and neglect, corruption, and exploitation at local, national, international levels that really lays a foundation for epidemics, not just of Ebola, but of other diseases. We know that disease thrives in communities that are in poor health with compromised immune systems, with neglect, corruption, exploitation at local, national, international level, and exploitation and poor health systems and lack of interest in investment in healthcare by governments. And I also think that Susan Shepler really pointed out what was true then and now is that local people are making the best decisions that they can with the experience and knowledge and resources that they have. And that we found that what is often seen as fear, resistance, and non-compliance is not actually, as she says, the result of ignorance, but of evolved psychological responses and as well to experiences within a poorly functioning healthcare system. And so what we did, where we were at, we worked, my husband worked in Uganda 2001, the latter part of an outbreak that occurred in the Gulu district. There are 425 presumptive cases and 224 deaths, a case fatality rate of 53%. Most of the patients were women, about 269 or 63% of the cases were actually women. 93% of the outbreak occurred in a district that had a population of about 470,000 people. And what was unique about this outbreak was that it occurred primarily among one ethnic group, the Acholi. We also worked in the Republic of Congo. This was a rural outbreak. There was actually 2 districts where the teams were sent. It was my husband, Barry Hewlett, Alan Applebaum, and myself. There were 143 cases, 128 deaths. Intrafamily and zoonotic transmission were particularly important, and as well there were approximately five different ethnic groups involved. So we were hired by the World Health Organization as anthropologists to essentially solve the problem of culture. Previously, in this region, international teams had been run out of the villages by the local people and met with resistance. So we, again, were hired to solve this problem of culture. Of course, as anthropologists, we went in with the thought that culture is not a problem and that culture matters, the cultures of local communities, the culture of international teams. And also to be clear that we don't just see culture as an internal belief system, but as well that it exists externally in socio-political structures, in institutions and governments. But primarily, culture determines health-seeking and health caregiving behavior. And just to talk a little bit about approaches and methods, because oftentimes we're approached after we have given talks, why can't you just send in somebody, not an anthropologist, somebody to go in and talk to the local people who's empathetic? We do actually have approaches and methods that are specific to anthropology that I want to talk about today. One is cultural models. Cultural models are how people understand a particular disease or domain. It has to do with signs, symptoms, terms, treatment, pathophysiology, risk groups, and these determine health-seeking behavior. How people think and feel about a disease determines how they seek treatment for it. Cultural models are dynamic and they're conservative. They can change based upon the acquisition of new knowledge and experience, but they can also be remarkably resistant to change. Cultural models develop early in life, are based on lived experiences, and are shared by others within a community. They have a strong emotional component to them, and the costs and consequences for individual change can be quite high. Unfortunately, those ascribing to the biomedical model often tend to dismiss or simply have no knowledge of indigenous knowledge and cultural models. Or they see them as problematic and something to overcome rather than something to build upon. What we learned is that to control Ebola epidemics is that you have to understand how local people think and feel about a particular disease, and as well biomedical care. And that we found that in the outbreaks that we worked on, that knowledge of both local and biomedical models and how people fluidly move between these models are what really contributed to the eventual control of the outbreak. Clinical medical anthropology, this approach was introduced to us by Dr. Alan Applebaum. As I said, he's a medical anthropologist, a physician, and also a healer who's based in Paris. He introduced this approach to us, and basically it emphasizes providing culturally sensitive care. So he assisted in the design of the isolation units and suggested replacing, and I think I have it, maybe not, here. He suggested replacing these tarps with the fence, and now we see them, they're ubiquitous in Western African countries where the outbreak is occurring. Just simply replacing the fence so that people could speak to their loved ones, they could see and visit their loved ones. And so what we learned from this is that transparency, both literally and figuratively, is important on many levels, and that to aid and control epidemics, you have to provide sensitive and humanitarian care to Ebola victims, living and the dead. That from the care they receive in the treatment centers to the burials, needs to be sensitive and respectful. Dunn's framework, Fred Dunn, a physician and anthropologist, developed a simple framework that we used to make use of. The framework is important, or was important to us, because it doesn't romanticize local cultures. It suggests that there are, of course, beliefs and behaviors that need to be changed. It suggests that national and international teams also may practice beliefs and behaviors which are health lowering. And it provides insights into structural violence as well, because it considers how forces outside of the community, the lack of, as Farmer says, the staff, the stuff, and core systems impact the community. What we learned is that most social science approaches in public health tend to discuss local cultures as a barrier to overcome. And little thought or consideration is given to the possibility that there might be actions the local people are taking that are useful and that can aid in the control efforts and can be incorporated into control efforts. And so our thought, what we learned, is that to aid in Ebola control, social mobilization teams, health educators, and clinicians can build upon the health-enhancing and cultural beliefs and practices from the local community. Individuals and methods, just simply to say that we used open-ended, semi-structured interviews with individuals throughout the community and in many different villages. We made a special effort to talk to women and children, primarily because when we were in, for example, in the Congo, there would be daily meetings held, and I would look around the room, there'd be maybe 40, 50 people there, and 3 women, I was one of them. And so even though women were providing the care to the sick in their homes, washing the bodies, they were the ones left out of the meetings and healthcare messages. So we made this special effort to talk to them. Our research methods were constrained due to the limited time to conduct the research and concerns over security. We were there in the Congo at the very beginning of the outbreak, and not all cases and contacts were identified. Also, the day before we got there, 4 teachers were killed And the healer that we interviewed actually handed us a hit list with about 20 names on it, and 4 of the names were crossed out, and it was the teachers. So we were somewhat concerned over our security, and this constrained our work. So the results, why were people running from the ambulance? This was one of the questions and concerns from WHO in Uganda. The healthcare workers, the international healthcare workers that were there, theorized that the patients were afraid of being buried at the airfield, and so when they died, and so that their theory was that's why they fled and from the ambulances. What we found, actually, the sources that we spoke to, that people were in fact fleeing, avoiding the ambulance, hiding because they were afraid, because of mistrust, and because of the lack of transparency. They thought they would never see their loved ones again if they took them to the clinic. And I think that David Bausch really made a point when he said avoiding health facilities is reasonable if those facilities are associated with isolation and death. And certainly that was their fear here, that when they would go to the clinics, they would never see their loved ones again, and most people going out came out in a body bag. The other fear they had was the Euro-Americans were buying and selling body parts. And again, their loved ones were taken into the clinic. They would oftentimes die. They'd be put in body bags, and they were never seen again. And they were not, the loved ones were not going to the funeral, practicing any traditional funeral practices. So they were not around at the time of death and not seeing their loved ones. People were not afraid of being buried at the mass burial ground. In fact, 96% of the adults interviewed, in fact, said that they appreciated that and that it was good to bury individuals there. What we learned is that simple measures, very simple measures, can increase trust, mitigate fear, and it's important to talk to the people, to simply not assume, to know what they think, need, and feel, but to ask. A lack of transparency, the tarps that I showed you increased or led to distrust. Not seeing the loved ones prior to burial, or not seeing the loved ones once they entered the clinic, also led to people fleeing, hiding, refusing safe burials. Do burials amplify outbreaks? Yes, they do. We found that they did. The careful washing of the body, the emotions, the dancing, the family harmony, the expressions of love demonstrate respect and care of the loved ones. What we found is that, what we are told is that the spirit is expected to stay with the family, close to the family, and that the body is to be washed and touched and remain a part of the family. We found in the Congo, we found in our work in Central African Republic, that the relationships, the obligations, the love that are extended to the living also are extended to the dead, that the relationship continues beyond the grave. So improper burials, if burials are not conducted properly, will cause harm and illness to the family, and the consequences for the family can be great. So what we learned is that there was a tremendous gender bias, that women, particularly in Uganda, represented 63% of all cases. And just to show you, here's a kinship chart, and as you know, the little red circles represent females who died of Ebola. So there was a definite gender bias. We did not find the same gender bias in the Congo, and I haven't heard that there's this gender bias here in West Africa. What we also found is that local people had special burial procedures for unusual circumstances, such as during an Ebola outbreak. And when the disease, the cultural model for a disease changed and was classified as an epidemic, burial practices were modified. And so there's very specific protocols that went with the cultural model of, and I'll talk about Gamo in a minute. The body wasn't touched, it was buried outside the village. An older woman or survivor of Ebola would take care of the body. The elders would go, after the outbreak was over, gather soil from the airfield, bring it back to the home, have a special ritual which would invite the spirit back to the home, back to the family, and then harmony was restored. So cultural models for illness, what we found in Uganda and Congo is that among the Acholi, that they switched from seeing Ebola as a simple illness using a variety of biomedicals such as malarial or antibiotics and indigenous cures. They then switched to sorcery, where they thought it was a poison called yat. Healers were called in to extract the poison. And then as more deaths continued after this, they then switched and began seeing Ebola as an epidemic. Once they saw it as an epidemic, then they shifted protocols, had special protocols and procedures for unusual circumstances. They isolated the patient, they kept children away. A survivor of Gamo would feed and care for the patient. They would keep all survivors in isolation for 1 month, and that they would bury individuals at the edge of the village. Let's see, in the Congo, essentially what we focused on was making all actions transparent, consulting family in terms of what they wanted buried with the patient. We would replace items, we would give and attend funerals. And so we had a list of recommendations, which again were evidence-based, and found really that simple measures went a long way to show respect and build trust. Now we're seeing the same sorts of things arising in West Africa. Are there commonalities? Can these lessons be applied to the outbreak? What we found in Uganda, in Congo, and actually in Gabon, is denial. And what we're finding in the US and in West Africa, denial, resistance, fear, distrust, problems with burial practices, quarantine, stigmatization, and then earlier on, a belief in sorcery. So what I'm going to do actually is just go over, skip ahead to, these are common human responses. They occur anywhere, any place, anytime when you have an acute or rapid killing illness. These are evolved psychological responses to, again, rapid killing diseases. They're shared. So this shows us there's a base of commonality that we can expect to encounter. And if you look on the human relation area files, cross-cultural responses, it's the same thing. It's flight, implementation of extraordinary therapies, blaming, stigmatization. Same thing occurred during earlier epidemics in the 17 and 1800s. Fear, fleeing, stigmatization, as well, lack of respect, lack of trust. So we suggest a multidisciplinary framework to understand Ebola and other diseases. There's an integrative, holistic approach. And I think just one thing again to point out is these responses we're seeing, whether it's in the United States, the fear, the distrust, these are evolved psychological responses that we can expect. And also the culturally constructed niches, that we're not just talking about internal cultural models, but culturally constructed environments, political institutions, and structures are culture. They're socially transmitted and certainly impact how people respond to outbreaks. Quickly, overall summarization of lessons: resilient communities. Communities should be the basis of control efforts. Community engagement. Engage the community as a partner in control efforts, involving them in discussions, what they say their needs are, what they feel will work, how they feel they're able to mobilize and help. Trust, learning that there's a lack of trust on the part of international teams in the ability of local people to aid in control efforts. So building trust and respect are essential. How to build trust? Responding sensitively, appropriately, quickly, being open and honest, transparent, being consistent in what messages are being sent, in control strategies. Supportive aid, of course, that is as well necessary, and just, again, not just supplying aid, education, but as well provision of food and medicine for endemic diseases, and then physical and psychological care for survivors and children. Human nature, fear. You know, we're seeing this again in the U.S. We're seeing it in many places. The fear of this Ebola, and knowledge and trusted information mitigate fear and stigma. Misinformation increases it. Inequality. Again, what we saw was just that women, children, and politically, economically marginal groups were not given the education and attention that they needed. Lastly, just to end on hope. Our research, we found that there's many stories of individuals helping others. We're a cooperative species, and hope is a counterpoint of suffering, and really it's these outstanding individuals who are going to save as many lives as technology, the isolation units, and the medicines. And just to end on what Panther Brick wrote about some time ago, is that it's the cultural values of harmony, unity, social responsibility, obligation to family and community, which will provide the bedrock of hope and resilience that will give order and promise of life. So, thank you for your attention.